Welcome to Endoscopy Now in today's virtual education program, optimizing outcomes with through the scope esophageal stents, size, strategy, and stent design in clinical practice. I am Nick LaPrairie, VP of Sales for TU Medical USA, and I will be your moderator. We are pleased to introduce today's speakers, Dr. Julie Yang and Dr. Shailendra Singh. Dr. Julie Yang is the Director of Comprehensive GI Cancer Program at Maimonides Health in Brooklyn, New York. Dr. Shailendra Singh is the Director of Advanced Endoscopy, Director of Bariatric Endoscopy, and Associate Professor of Medicine at West Virginia University in Morgantown, West Virginia. Welcome, Dr. Yang and Dr. Singh, and thank you for joining us today.
Thanks, Nick. Thank you for everyone joining this evening and spending some time with us. We're just going to get straight into the program. Optimizing outcomes with through the scope esophageal stents. These are my disclosures. So today we're going to talk about a couple of things, and hopefully at the end you'll have some takeaways where you can either reinforce your practice currently or add to your knowledge in your practice. But our objectives today are to talk about an overview of esophageal stent designs, highlight important stent characteristics, review the technique of deployment, particularly the TTS, and also review clinical indications for esophageal stents, both on-label and off-label. We're also going to illustrate some of these interesting cases that Dr. Singh will present, and also all the while, hopefully share with you some tips and tricks. So we're going to start first, think broadly and talk about what is our goals with stenting. And before we get started, it's for those of you who are history buffs. Stent actually derived, that word came from a dentist back in the 1800s who developed dentures and used the word stent. Then later on in the 1900s, a surgeon had used it for what it is intended to now, which is bridging. So in 1974 was the first time that we had used a stent in terms of a GI function, and it was through a percutaneous transhepatic catheter for obstruction of for biliary obstruction. And then in 1980, Dr. Sohindra and Dr. Reynolds Fredericks was able to place the first endoscopic biliary stent. So sort of that's the history and the iterations of where stents have come from. And, we've really come a long way. Today's talk is obviously talking about esophageal stents, but I always try to appreciate, where we've come from and where we are going with our technology. So going back to stents and their goals, what are we trying to do? Two things. One, the stent is supposed to expand and keep the GI tract lumen open. And that's particularly talking about the radial force. A second function of the stent is to seal the GI tract lumen. And so that the function of that is to allow for tissue healing by secondary intention, or it may be so that you can buy time to the next definitive treatment. So those are the two things that you sort of think in your mind as to why I would want to pick a stent in a particular clinical scenario. So the advantages are that stents cover a large area. They can negotiate through angulated GI tracts, and they're quick and efficient in deployment. So particularly the TTS, which is what we're talking about today. But there are some disadvantages because obviously nothing in life is perfect. You've got pain, obstruction, but really the Achilles heel of stenting is migration, which we will hopefully cover some options today. So talking about stent design, it's a lot about sort of the details of the stent design. And there are a lot of little nuances and iterations. And I'm going to refer you to our ASGE document that came out last year talking about enteral stents in benign and malignant disease. And there's a table in that paper that really goes through all the different types of stents that are on the market and all the details that if you'd be interested in knowing, that you can refer to. But talking about the major highlights, stents these days are now all made out of nitinol, which is a nickel and titanium material. Stents usually started with plastic stents, then came out with all different kinds of metal stents, including stainless steel. But it seems like the sweet spot at this point is really nitinol. And the reason why is because of its elasticity, its shape memory, and conformability. And material, the nitinol, plus the construction together makes what we refer to as flexibility of the stent. So construction of esophageal stents come in different flavors. They could be laser cut, braided, or hook cross. And the details of those things may or may not be important to you in day-to-day practice, but some features of it that maybe you want to remember next time that you have a clinical scenario and you're thinking about a particular stent that may address your issue. Other important things about stents are that you have covered and partially covered. There is one stent on the market that's completely uncovered, but we've really moved away from uncovered stents and now are using solely covered and partially covered. And you can see on the picture here is that it's a silicone covering of basically the body of the stent, leaving the bare ends bare. That's the partially covered. And the idea of that is to reduce tissue ingrowth versus fully covered, where the silicone covering is covering the entire entity of the stent. And another important factor of stent design is the way that the stents are deployed. So traditionally, they are over the wire, meaning that the delivery catheter of the stent is not small enough to fit through your working channel of your scope. And so you have to place a wire first, take out your scope, and exchange your scope for the delivery catheter. And from there, you can either do a side-by-side and reinsert the scope, or you can just do everything under fluoroscopy. So that's sort of the over-the-wire technique, which is traditional. And now with the advent of through-the-scope delivery catheters, the deployment is much easier because the catheter is small enough to fit through your working channel, and you don't have to do any switching on and off or any exchanges, which makes life much easier. Diameter stents also come in a wide variety depending on what your needs are, but by and large, we use 18s to 23s, but they come, as small as 12, 14, and 23 is the largest. And just to know that the 22 millimeter is the largest diameter TTS on the market. That is the Taewoon stent. And we'll talk about, particularly in the cases, show you what that's like in practice. Just as they come in a variety of diameters, the stents also come in a variety of lengths, depending on what your area and your need is. But what you should also be looking out for is foreshortening. For laser cut stents, the foreshortening from that design is virtually nil. But there is foreshortening depending on the construction of the stent. And those things, again, referring to that table in that paper, gives you an idea, but they can range all the way up from minimal to 40% shortening. So it's variable among the stents. The other important feature about stents, particularly if you're using the covered variety, is that there's a suture either at one end or both ends that allows you to grasp it and give you the portions of where you can either reposition it or remove it altogether. And another feature of some stents is the way that it's deployed. So whether it's proximal deployment or distal deployment. So most of the time stents are distally deployed. And I would say, so that means, if you're looking at something that's in the distal esophagus, GE junction, you're deploying from distal up to proximal. So what you're seeing is just going to be the proximal end of it. But sometimes you may want to use the proximal deployment, and that might be clinically relevant. For instance, if you're dealing with a proximal cervical esophageal stricture, where you really want to be sure of where your proximal landing point is of the stent, because you're concerned about the position towards the UES, and you have a lot more laxity distally. So that might be something that might be important to you. There are other features of stents, including anti-migration features, which, we talked about a little bit, are these dumbbells, which are the flares, which are common in most stents. But one stent variety also has these anti-migration fins. And so that's the purpose of that design. So some special considerations, which I sort of alluded to, but the big picture is that you really want to have proper sizing to match your clinical scenario. So if you're talking about lengths or lengths along the esophagus, two major points you have to be concerned about is across a GE junction. So you don't want, if you're going to put a stent across the GE junction, which sometimes you have to do, you're going to be concerned about reflux. You're going to be concerned about impaction of the stent if it's too long against the opposite wall of the stomach. That could lead to bleeding, ulceration. and eroding that wall. The other problem, actually, it's pretty practical also, is obstruction from stomach folds and vaginating into the stent, particularly large caliber stents. Even if you have it placed perfectly and it's short just across the GE junction, the stomach is sometimes the folds roll up into that area and sort of like ball valve that stent. So it could be perfectly placed. There's no food or tumor ingrowth, but that's just sort of the nature of when you put it across the GE junction. And then talking about proximal esophagus, as I alluded to, the closer you are to that UES, the patients will feel more pain or discomfort, particularly also because the proximal esophagus is smaller in diameter than the rest of the esophagus. So you have to take that into account as well when you're concerned about considering what stent size you want to use in the proximal esophagus. If you're talking about diameter, it's obviously, is wider always better? Not necessarily. So if you are dealing with a normal esophagus or GI tract lumen, so there's no stricture involved, then you've got a pretty good sized lumen that that the stent has to really sit across. And if you want that sealing function of the stent, you're going to have to pick something that's a wider diameter. Same thing for if you're considering extrinsic versus intrinsic tumors. Most of the time, extrinsic tumors are not going to be as tight as intrinsic tumors, but obviously that's not always the case. And just to consider, to sort of put into the back of your head, is that large caliber stents may increase the rate of fatal complications from stent erosion through the esophagus. So not bigger is not always going to be better. So what about when situations where you need a smaller diameter? Sort of what we talked about with proximal esophageal areas. You want to minimize that globus sensation and pain. Also with severe strictures. So if you've got a severe high-grade malignant stricture, it's really like a pinhole. All you can do is get a wire through if you're even lucky. You don't want to just open up that area with the largest diameter stent that you can see. Sort of akin to the idea of dilation, right? So always we follow that rule of gradual, slow, maybe the rule of threes. Something to consider with stents too. So you don't want to go from pinhole to the most giant diameter you can. You sort of want to think about something that's slow and steady, particularly in that instance. Same thing for patients who've had prior radiation to the esophagus or wherever you are. That tissue is not going to be the same. It's not going to be as pliable, and so you want to be concerned about maybe potentially putting a smaller diameter stent. And again, migration, which we're going to be talking about the entire time, because again, it's our Achilles heel. The partially covered sort of address that issue where the bare ends, there's tissue ingrowth, so there's less migration. The iteration with the fins is better than fully covered totally without fins. But if you look in the literature, risk factors for migration, all fully covered stents have the potential to migrate. Stent diameters less than 20 millimeters. Benign indications, and prior esophageal surgery. So deployment feature through the scope. The first major shift I would say in clinical practice for esophageal stents was when we first had this fully covered design. So before it was uncovered really for malignancy, and then we realized it just tumor ingrowth happened all the time and it obstructed. Then we did, partially covered, which is, you have the body of it being covered, so you won't get as much tissue ingrowth. And that's, again, still great for malignancy, but that major shift in clinical practice for stents really came when we had the fully covereds, because then we went from something that was permanent to something that was removable. And so that expanded our indications and usage outside of what's on label. And I would say that the next major shift in stent design is this through the scope deployment system. And the beauty of it is that we don't have to exchange. It's not cumbersome, and it's sort of akin to the idea of going through putting in a lumen opposing metal stent, the old-fashioned way, which is multiple steps, versus the current way, which is cautery tipped, and you just go right in. So it just makes things life easier. And so TTS is really that for esophageal stents. No need for wire exchange, direct visualization the entire time you're deploying. And that leads to efficiency in endoscopy. And sometimes, I would say most times, it obviates the need for fluoroscopy. So all those silly things you do with the paper clips or whatever radiopaque material you use to estimate your markings and your landmarks sort of obviates that need most of the time. So let's move on to indication. The only on-label indication for esophageal stents is for malignancy. Esophageal strictures caused by intrinsic and or extrinsic malignant tumors. That's it. And so it comes in two flavors, either the treatment of malignant dysphagia or the sealing of malignant fistulas perforations. So we'll talk about malignant dysphagia because that's predominantly what we use it for. And as we know, 3/4, a majority of esophageal cancer patients present with dysphagia. And we know that in studies before, dysphagia, when patients present with it, they already have locally advanced disease. So on EUS, we already know that they have T3, T4 disease. And the more severe their dysphagia is, so if they can only swallow up to liquids, then that positive predictive value for locally advanced disease is almost approaching 100%. So when they walk in the door and they have dysphagia, I already know in my mind that they're going to have locally advanced disease. And so when they come to you, you have two goals in mind. One, obviously reestablishing some sort of the lumen so that they can reintroduce orals, or your other major issue, which is nutritional support, because survival has been seen to be parallel to nutritional support. So in this regards, even though we put stents in, most of the time patients are going to need feeding tubes. And one thing about feeding tubes is that if they're esophageal cancers and they're potentially resectable, you will want to talk to your surgeons because most of the time they don't want you to put gastrostomy tubes and prefer jejunostomy tubes so that they can, it won't mess up with their conduit formation for surgery. So the technical success is very high. Clinical success is also very high. I mean, stents are wonderful for rapid relief of dysphagia. And usually that relief is almost immediate in 1 to 2 days. And the adverse events are acceptable: bleeding, pain, reflux, if it's across the GE junction particularly, and severe pain enough that you might consider actually taking out the stent. So moving on to sealing or fistulas, TE fistulas, they occur 5 to 15% in adenocarcinoma of the esophagus, less than 1% in primary airway cancers, thank goodness, because that's horrible and challenge to take care of. But even SEMS placement in and of itself, 4% is related to fistula formation. So these are the things you sort of have to think about. And the goals here are a little bit different. It's really for quality of life, reducing respiratory symptoms. And according to the American Chest Physicians Guidelines, you sort of have to talk if there is a TE fistula with multidisciplinary setting. Most of the time, if there's airway stenosis that's less than 30%, esophageal SEMS alone is good enough. More than that, then you'd have to consider respiratory dual stents or considering other interventions besides the SEMS. So the clinical success is widely ranged, but factors associated with failure, which I think is important, are large fistulas greater than 1 centimeter, proximal location, the more proximal you are in the esophagus, and overall poor performance status of the patient. So malignant dysphagia, it's a busy slide, but I'll give you the sort of, it's not so hard because it's sort of the punchline. If the patient's potentially resectable, there's really no role in SEMS. And the reason why is because there have been studies showing SEMS has worse outcomes in patients who are potentially resectable. And it's not recommended as bridge to surgery. So studies have shown that people who are potentially resectable and who get SEMS, particularly in the neoadjuvant setting, they have less R0 resection. Their 3-year overall survival is less. SEMS alone was an independent predictor of poor prognosis. And although dysphagia improves, because again, immediately we see that dysphagia improves, but overall in the long term, it had no impact on nutrition when you measure it with weight, BMI, and albumin. And so when you think about it with patients who have cancer, you don't want to take away that potential curative intent treatment. And so you're a little bit more conservative And because of the fact that there are more adverse events, and you can get them through nutrition, either through alternative methods like feeding tubes, it's best that SEMS is not placed. But again, in all these situations, it's very challenging, and the best is to manage it in a multidisciplinary setting. So if you're unresectable, then you have a wider range of options of treating malignant dysphagia. And whether that's brachytherapy alone, or chemotherapy, or radiation, or combo with or without STEM. So the broad picture is that you have a lot more options if they're unresectable. And so again, that's a conversation with the cancer team to figure out where the patient lies on before you decide if SEMS is something appropriate for the patient. But studies have shown that brachytherapy is more durable in results for dysphagia in the long term than stents, and they have less adverse events. And so that's why it's perfectly fine to do brachytherapy if that's what you have at your institution. Combination therapy, chemo, radiation with stents has a better long-term relief of dysphagia in the long term. There's no difference in the short term, less than 3 months. But that combination therapy with stents improved overall survival, but there was a tendency to have more chest pain with the stents versus combo therapy without stents. And then it gets even easier if they're unresectable and they've had prior radiation therapy. So essentially, you've really running out of your options. They're not going to irradiate again and again, potentially, depending on what their performance status is. But malignant dysphagia in this sort of grim setting, SEMS is the way to go. But you do need to know that there are increased adverse events with prior chemotherapy, radiation therapy, and there is more pain, pneumonia, fistula formation, and in very frail patients, so performance status greater than three or four, SEMS is still effective in alleviating dysphagia, but again, the big picture is that the prognosis remains poor and the overall survival is only a few months. So moving on to indications that's off-label. The first big one is refractory benign esophageal strictures. This is sort of like esophageal strictures broken down to simple and complex. So we're really moving on to the complex, where they're longer, they're angulated, tortuous, high-grade stenosis. These are the etiologies. And we're talking about refractory, which by definition is the inability to achieve a lumen diameter of greater than or equal to 14 millimeters, despite more than 5 dilations in a biweekly situation. And that's about 10% of your esophageal strictures. So in this group, if you look at the algorithm that's suggested, so you try dilations a couple of times, that's the answer. Try it again in shorter intervals, and then you do your incision therapy if it's potentially like an anastomotic stricture, or you can even do steroid injection. So you basically exhaust all of the options, and then you get to before surgery, because nobody wants to do that. And self-dilation, I don't have very many patients who sign up for that. Your last sort of rescue is stent placement. So the advantages are that you have continuous dilation with less repeated procedures, and the stent causes stricture remodeling. The indwell time is about 6 to 8 weeks, but you can go up to 12. But that's when we say that we should really start thinking about removing it, and it becomes obstructed. And again, SEMS comes in a variety of lengths, so you can treat any length of a stricture. The disadvantage is that the long-term clinical success is not great. And again, if you look at it, remember, this is rescue. I mean, they failed all of this. And so you're getting to this really subset of patients who are very complex. And so the clinical success rate is really explained by this scenario. Stent migration is 30% in this scenario, and so fixation is recommended. And again, adverse events to consider. Severe adverse events related is perforation, bleeding, and even fatality. So moving on to the next benign indication that's off-label is management of perforations. So depending on where you are in the esophagus, whether it's cervical, thoracic, abdominal, and these are the etiologies, most of the time it's something iatrogenic, so something we did, or non-related, what somebody else did. So TEEs we've got called in, things like that. So those are, majority of the time is iatrogenic, but again, sometimes you'll have emergencies, foreign bodies, and Boerhaave's. So, principles in general for endoscopic closure, because obviously it's not just put a stent and walk away. Factors to consider when you're trying to take care of the situation is the size of the perforation, the location, the type of perforation, the time of when it occurred. So, less than 24 hours is always the best. Presence of any fluid collection that you may have to manage, what your expertise is at your institution, and obviously a multidisciplinary management because these are not easy situations. So quick management is switch to CO2 if you haven't already. Source control, which is very, very important. If you have an abscess, you're already sort of down in chips because the mortality is greater than 60%. So this is already by and large a very challenging situation. But if you have a collection, you need to drain it, divert the juices, and then decompress if you're having to deal with any air. So this is an algorithm for esophageal perforation, which is sort of, I like it because it's very simple and kind of puts you through what your choices are depending on what your scenario is. So if you've got that collection, then you've got to drain. If you don't have a collection, then you can consider going straight to endoscopic therapy. And depending on the size of your perforation, so stents come in when you consider things greater than 2 centimeters. And so if it's too large for that, these are your options. And if you're going to go through stents, we obviously suggest fixation because of that migration issue, because the lumen size is normal. So efficacy, technical success is the same as when it's in any other scenario. Clinical success is 87% in this study. The length of hospital stay was 12 days, which is pretty remarkable for a perforation. And the perforation ranged in size. 83% of the stents were removed a little over a month. Stent dwell time was a little bit longer in leaks as it was for perforations. And really the most important thing, which is the predictor of success, is timing. So you have to recognize it and try to manage it within 24 hours. So the last clinical benign indication would be uncontrolled esophageal variceal bleeding. So when does this situation happen? Luckily, not very often. So obviously gold standard is band ligation, but in 5 to 15% of the time, there is a situation where band ligation is going to fail. And it's sort of a multitude of reasons: insufficient ligation. So you put it on, it slipped, or maybe you didn't get exactly where the nipple is, or the red, or the bleeding spot is, or the platelet plug. It could also be from misfiring a band. Also, sometimes if it's just torrential bleeding, so you're sitting there, you're cleaning, and you really think you know where that bleeding varix is, but you just can't see. Then you obviously can either shoot bands blindly, but the success of that is going to be very low. And same thing, if patients have had varices ligated and they've come for obliteration, but then they come back for bleeding later on, in that area, it's all going to be scarred down, and we've seen that, and you just can't suck up the tissue, suck up the varix to get a band ligation around it. So these are, scenarios that we will see, you have seen, and really we're talking about this where you're in a pickle and you have failed ligation. So your rescue therapy is that you need to temporize the bleeding until you can get to definitive therapy, which by and large is going to be TIPS. And so these are the new guidelines from various organizations. So here on the right is from the ASLD guidelines in 2024. So band ligation, hemostasis not achieved. You've got choices of balloons or esophageal stent. And then that buys you time to get you to a more definitive TIPS. The SG guidelines also recommend fully covered stents as a option for this rescue bleeding. And also the Baveno consensus in 2022 goes actually another step further and says SEMs are efficacious as balloon tamponade and are a safer option. So refractory esophageal variceal bleeds, balloon tamponade, these are your choices. And I can tell you myself that I don't remember the last time I put these in. It's always very torturous and cumbersome to get all the materials to even do this. You always forget in the middle of the night which balloon goes where. So it's really so cumbersome. And I never thought that it was anything that was user friendly. But what is user friendly is a quick deployment of a TTS large caliber stent for variceal bleed tamponading. And really, better. There's only been one randomized study, although it was very small in number, but it showed that there was better efficacy, less transfusions, less adverse events, although stent migration was still 18%. It was faster to place than this whole Getty up setup. And the best, I think, for me practically is that the indwell time is longer than just 24 hours. So, you've got this happen on a Friday night and say, I don't know, the IR liver team, nobody's around until Monday, or no one can give you a definitive answer till Monday. In 24 hours, you have to deflate that balloon. But if you've got the SEMS in good place and you've got a good seal, you can leave it in there for a couple of days. And so it just buys you more time. And again, thinking about, the clinical scenario here, which is very challenging. It's a difficult situation. Whether you go with SEMS or balloon tamponade, there is no difference in 6-week mortality. And that just goes to show you, just how sick the patients are and how close to mortality they are. So I'm going to turn it over to my colleague for highlighting these cases and indications with some scenarios. Thank you.
Thanks, Julie, and thanks, Nick and the Tevu team to invite me to give this lecture. So I will be talking about through the scope stent, and we have a large advanced endoscopy program at West Virginia University, and we use these stents a lot. So I'll be sharing some practical tips and advices and show you some cases we can use these stents for. So these are my disclosures. Okay. So the first case is this is a 72-year-old male who presented to us with the complaints of dysphagia and also ongoing GI bleed. So we perform a upper GI endoscopy and we see an ulcerated fungating mass with some bleeding. So decision we make here is that what should be the next step. So we decide on putting a fully covered metal stent, as our practice have moved to use more fully covered stents because of ease of removal of these stents. Now, then we decide on the size of the stent. So it's almost a 10 centimeter mass, and we opted for a 15 centimeter stent based on the availability. And if I look at this, my scope is able to pass through this, and this proximal esophagus is dilated. So we went for a 22 mm by 15 centimeter Tebu esophageal stent. So what I do is when I place these stent, I will generally use a guide wire, and I place the guide wire as deep as possible. Having a guide wire in the duodenum or deep will give you, one is a safety mechanism that the stent will always be on the wire. Second thing it does is that it also provides you a traction when you are pushing these stents. So I'll try and keep my wire as deep as possible. And when you look how to deploy this, so once I know I have positioned myself, my wire is deep, I pass this stent through my scope. And there are two ways you can deploy it. Like suppose you're not using, you are in a situation such as a bleeding or an emergent situation, and you're not using a wire, you can start directly deploying them under vision as I'm doing it here. But what I usually do is I will exchange this stent over my wire. That is, I am pushing the stent in while pulling my scope back. So if you will see here, I deploy a little bit, but what I'm really doing is also pulling my scope back, and then I will also do some measurements, and I have already decided where proximally I gonna end the stent. So I will kind of continue to exchange, and then I know this is a safe area of landing for me. This is proximal to the mass, at least 2 centimeters proximal to this mass. I have a healthy esophageal mucosa here because I most of the time will fix these stents with suturing or clips. Um, and then I control this yellow marker. The yellow marker, it's very important to control this yellow marker. And you apply a little bit traction, pull it towards you, and control it and keep it at a point where you want to end the stent. So here we have completely deployed this stent across this stricture. Um, so this is the Tevu esophageal stent we use. So the largest diameter available in United States is 22 mm. And if you look at the stents that are wire guided, the largest diameter is 23 mm. So we have a very close approximation of size there. And generally, the situations we are placing in these stents in and also the off-label use, they're usually not very tight strictures, perforations. This 22 mm stent has been a game changer, and we do use it a lot. The stent size, as he said, what I'll do is, let's say if my mass is at 30 to 40 centimeter, then I will say I'm using a 15 centimeter stent. Then I will know, okay, my proximal end will be at 27 and my distal end will be at 42 centimeters. So I will at least try and do that measurements before placing these stents and keep at least 2 centimeter beyond the proximal and 2 centimeter at least beyond the distal margin. And then also you have to account for obviously locations as a G junction. Always, if you are in the duodenum, you have to also account for any tortuosity or the angulation that stent is going to take. Also anticipate for the expansion. Usually there is a 2 to 3 centimeter foreshortening of the stent. So although initially it might look that the stent extends beyond, be much beyond the stricture over a period of time, the stent will expand and will foreshorten. So usually when these stents are fixed, let's say if I fix a stent in the esophagus with esophageal suturing or even with a over the scope clip, the foreshortening usually happens on the distal end. So I think this is something to keep in mind. So moving on to another case. So this is a case where we saw that this patient has multiple failed dilation. Now, his next option would have been surgery. Before that, he was sent to us for placement of an esophageal stent. So this is a patient who's already here and is on a fluoro table. So I see these kind of strictures. What we can do here is we can use fluoro guidance and easily place a through the scope stent. I'm using a therapeutic scope, so all these through the scope stents will be placed through the scope. Will need a therapeutic channel. So what I can do here is while I can pass this catheter extraction balloon, I will inject some contrast. I see my wire is curled in the stomach. I see some contrast in the stomach and outlining of the contrast as well. With this injection of contrast on fluoroscopy, I can see how long is the stricture, how narrow it is, and then I can place my stent under direct endoscopic, either endoscopic and fluoroscopic visualization. Here we will see the stent is expanding, and then I have marked my dimension. I'm controlling it here. I can also use fluoroscopic guidance to place these stents. This is a patient, again, a patient with benign esophageal stricture, severe stricture, failed multiple dilation. He came to us for a repeat dilation, but talking to him, seeing the stricture with no improvement, despite multiple dilation, a decision was made to place a stent. So it's possible you can place these stents, but you have to be careful. So here what we did is we dilated the stricture first. So with dilation, we were able to pass the scope through. And after we were able to pass the scope, a guide wire was placed deeply into the duodenum, and then the scope was withdrawn, and then on a therapeutic scope, a stent was loaded and then passed over the guide wire, and the stent could be placed without the use of fluoroscopy. You can even use smaller diameter scopes and place these stents if you don't have fluoro available. But again, these needs to be done. You need to have enough experience and technical expertise to place these stents without fluoroscopy when your scope is not passing. So I think one important thing is placing these stent, but most very important thing is post-esophageal stent care. Now you can see this is a patient where the stent has migrated in the stomach, and this is on an endoscopy. So what I usually do is put them on a clear liquid diet for 24 hours, then advance to a full liquid diet, and at 72 hours is when I will advance to a soft diet that allows the stent to expand and force short. And we give them written instructions with the stent for good precautions, medications, PPI twice daily. We'll put most of them on PPI twice daily. Now, if few 1 or 2 days later, patient continues to has dysphagia or has other symptom, then we will get an X-ray or an esophagram to make sure that the stent has opened, it has not migrated or misplaced. If the symptoms persist, then we'll perform an endoscopy to assess this. So this is a patient who had a esophageal stent placed, and you can see this stent is sutured on the proximal end, and then he continued to have dysphagia despite a stent placement. So we checked on an X-ray, looked like the stent was still in place, was not migrated. So we performed an endoscopy, and on the endoscopy we could see this is a stent placed much proximally, and the tumor still extends on the distal aspect of the stent. So what we're trying to do is see if we can manipulate. We're not using fluoroscopy with this case, so we will try to see if we can manipulate our way into the stomach, and carefully I'm trying to advance my scope and trying to see if there is a space and I can get to the stomach. Once if I'm able to get to the stomach, then I can use a through the scope stent and place it, and if not, then I would have put the patient on a fluoroscopy. So here after some struggle, we were able to get into the stomach, and then in the stomach again I placed a guide wire, and over this guide wire we advanced a through the scope stent, and again I'm exchanging, pushing my stent in while pulling my scope back. And what we planned is that we will place this stent across all this malignant mass, and somewhere in the within that previously placed stent. So you can see this is the stent. I like my position here. I have the yellow mark, and then I'm able to deploy it. Now, other thing, important thing, practically I want to point out is this is the suture or this white thread that can be used to manipulate the stent. So if you have placed a stent and you don't like your position, using a rat tooth forceps, you can pull this string in, make sure you have an appropriate placement. Like here, I have done my measurements, and accordingly, I want to place it across, and I am able to adjust it. Similarly, if we want to remove the stent, you look for this white string, and some stents will have this yellow string, and you can pull this string. What this string will do is constrict the stent, and then that makes the removal of these stent much easier. So one of the things we talked about is stent migration, and I think that's one of the most common complications. But we have now overstitch endoscopic suturing, X-Tech, and the Vasco stent fixed used. So we recently performed a randomized control trial, and to our surprise, what we see in the control arm where these stents, esophageal stents, were placed, without any fixation, the migration rates were up to 60%. And this is a randomized prospective study, so we are actively following these patients clinically along with chest x-rays to look for any migration. And with endoscopic suturing, we were able to reduce these migration rates significantly. And within this randomized control trial, almost slightly less than half of our patients we used were through the scope stents, which were kind of similar in both the arms. So one thing to see is that TTS stents will have a smaller delivery profile. These are 10.5 French. That is why they are able to go through the therapeutic channel of the scope versus the over the wire stents will have a bigger delivery profile. So one of the drawbacks can be with a smaller delivery profile that they have a decreased radial force while they expand, and that can increase the migration. We are presenting our experience with these through the scope stents at DDW this year, and we noticed migration rates of around 11%, and these stents were predominantly fixed using the overstitch device. So I think fixation is very important, especially using through the stents to prevent a migration. So, the technique used for endoscopic suturing? So, this is a case where a stent was placed and it migrated. Again, we were able to salvage the stent, pull it in the esophagus in the right location, and then we performed endoscopic suturing to prevent it. So, the technique I use is, and we used during our randomized control trial, was we take a deep bite on the esophageal wall, and I use suction and without any helix, and then take one bite on the stent and take bite again um, on the esophageal wall, and then a second bite is taken on the esophageal stent, followed by few bites, again deep bites on the esophageal wall. We place two stents, preferably on the opposite wall of the first stent. So here you can see, similarly, I'm placing the second suture in the esophagus to fix this stent. So total of two sutures are placed. Another important thing to mention is that we cinch these sutures loose. So as opposed to a defect closure, how you want to keep the cinches loose to allow for the stent migration and any movement of the stent that might happen with foreshortening or when the patient is eating food. So I think so these were the on-label use with strictures, and we talked about that there are a lot of off-label use, and we find ourselves, especially in today's world of therapeutic endoscopy, where are doing more and more complicated procedures. So these stents are a valuable tool. So especially if you are in the duodenum or even in the stomach in a difficult angulated anatomy, over the wire stents will not have enough traction and they are more straight. So those stents will be challenging to place, but through the scope stent is if your therapeutic scope is able to go through that angulation, then these are where you can directly deploy them, and they can be deployed in a more controlled manner. In situations such as we talked about the esophageal varices bleeding or perforation with dilation, they can be used as a rapid rescue therapy, and there is no need to use the endoscopy. So this is a case I did recently. This is a patient who had a post-ERCP, pancreatitis, then a post-ERCP perforation. He has a defect closure that failed, and he performed a fistula, and then there was an associated fluid collection that was already drained. So now you can see he has a biliary stent that directly goes into the cavity, and the cavity is already, there is a pigtail catheter inside this cavity. So the cavity is well drained and it's almost collapsed. So what we did is first we adjusted this biliary stent out of this fistula because he was having a lot of biliary drainage in liters every day. So after that, then I think again, so you want to make sure when closing these fistulas or managing them, you want to make sure there is no collection. So we looked at inside this cavity. The cavity is collapsed. There's no collection associated with it. But what we noticed is that this patient also has a distal obstruction in the duodenum. So if you have a distal obstruction, that obstruction won't allow allow this fistula to heal. So I think then thinking what we made a decision to place a stent, because with the stent, what we can achieve is we can treat this stricture in the duodenum, as well as we can keep the stent to cover the fistula and decrease the drainage through this fistula. So I was able to pass a wire across it, and then I will trying to manipulate my position to see if I'm able to get across this stricture. After some struggle, I was able to get through it. So then we decided we're going to use through the scope stent. And then again, if I look at this stricture, is looking tight, but still my scope is able to go through, and I feel the duodenum bulb is pretty dilated. So I need a maximum size of stent I can use here. So again, we went for a 22 mm stent to place across this stricture, as well as bridge the defect we have, the fistula we have in the duodenum. So I'm exchanging, pulling my scope back, pushing my stent, and then what I want to control is my yellow marker or the proximal end of the stent, and I can see that I have a fistula. I want to keep the stent over this fistula, and then I controlled the yellow part of my of the stent, and I'm able to place this in the duodenum. Again, to prevent migration, I used overstitch, and we were able to secure this at the gastric pylorus. But in situations, then you can see this is a patient again with a duodenal perforation, and you can see some contrast extravasation. The patient was transferred to outside hospital. So first thing we did is there was place a drain across this collection, and then we perform an endoscopy. We couldn't get our scope through the stricture, but we were able to get a wire across and inject some contrast through it. So you can see there is this is a very angulated stricture associated with this perforation. So using fluoroscopy, since we can go through it, in this situation, you will have to use an endoscopy, use fluoroscopy to place these stents. One thing I like to point out is that we can adjust these stents. So this stent is, if you can see, here is my contrast extravasating, but my stent is distal to it. So what I will do next is I will use a rat tooth forceps and try and pull this stent to position it well. So I pulled it back, and now looks like we were in a situation where this is across this perforation, and it's going through this angulation as well. In situations where overstitch use might be difficult, I also use X-Tack to fix these stems. This is a example where in a situation, patient with wound and gastric bypass has a stricture after dilation. He had a deep esophageal tear and some bleeding. And to salvage this situation quickly, we were able to place a fully covered stent in the esophagus and fix this stent to prevent any complications. So in conclusion, through the scope stents and usually availability of larger size stent has definitely expanded our endoscopy toolbox, not only management of strictures, but also for a lot of complications that we see in therapeutic endoscopy. It's an easier deployment, especially very helpful in difficult angulated anatomy. And endoscopic placement can improve control and precision. In some cases, fluoroscopy may not be required. In complex situations, it can also be used in urgent rescue therapy. And in our experience, we have used it for a lot of both standard on and off label indication, and we used fixation to prevent stent migration. Thank you.
Thank you, Dr. Singh and Dr. Yang, for sharing your knowledge on optimizing outcomes with through the scope esophageal stents. We will now move into the Q&A portion of the webinar. We have two questions that have come in. One is, so for refractory bleeding for esophageal varices, what size stent are you using for TTS?
For the largest stent that's through the scope, as we were talking about, it's the 22. And so if something where you're in a quick and emergency situation like torrential bleeding, you really want to have the largest diameter because you want to seal and mimic as much of the diameter of the normal esophagus as you can. And you want to do it quickly. And so no scope exchange and things over the wire. So although Dr. Singh was mentioning that the 23 is the largest, that's an over the wire stent. But if you just want quick deployment, 22 is the largest in the TTS. And so that's the diameter that I would use.
22 is the largest available diameter, and you have to look at the esophagus. And here, what we want is a tamponade effect, so good radial force. So larger diameters will be helpful.
Any preference or suggestion on a length?
So length is usually because it's depends. Usually the varices is mostly in the distal esophagus. So I think you have to, again, when you're doing an endoscopic exam, you have to estimate where you want the proximal end of the stent, where you want the distal end of the stent, and then based on that, you have to estimate dimension. It also depends on the availability of these stents. So what we keep a 10 centimeter, 12, and a 15, and most of the time we are using a 15 centimeter stent. But in this situation, I think because it's rapid rescue, the length, I think 15 or 12 is fine because that can provide tamponade distally to the entire esophagus.
Yeah, I agree. I think in esophageal varices, most of the time it's distal. And sometimes you can see with your scope, how high the chains go up. Usually the bleeding is something distal, but I also use something pretty long and conservative with my length to cover as much of the esophagus as I can. And I also give a longer length, not so much as a foreshortening, because it's going to be only in there for such a short period of time, but also because I want to make sure I have a landing pad proximally so that if I want to fixate the stent, I'll be far away from varices and it won't be an issue. So those are the sort of things that you have to consider.
Is there any significant migration of the stent within the stent? And if so, what can be done to help mitigate that?
So yeah, I think placement of stent within the stent, and then the risk is that if there can be migration of the stent. And I think we have published few case reports with it. What we do is it will be very hard to get an overstitch device or even using over the scope clips, because if you take that within the stent, it can basically displace that stent as well. So X-Tech is a good fixation method in those scenarios, because what you can do is you can use a regular therapeutic endoscope that should be able to go through your stent, and you can use X-Tech to suture it. Other thing will be is place the distal stent first, suture it, fix it, and then place a stent within that stent, and then suture the proximal end of the second stent.
I
But we
think
use X-Tech in scenarios where it's difficult to get.
Yeah, I mean, I agree. I think the through the scope suturing really is nice, and again, in the same lines of TTS and really being able to efficiently do your endoscopy. But just for the audience to know that that's obviously off-label, and so something to think of. But other interesting things, essentially the jury's out as to which is the best fixation in what scenarios. I think, the studies that Dr. Singh has is really elucidating further and further where we need to be as to what, how best we can fixate. But again, the jury's out still. So I think the idea is as long as you know that if you're going to use it for a benign indication and you know that the migration risk may be high, potentially in perforations or angulations like we talked about, you really don't want that stent to fly. You just need to think about fixating. So that's sort of the general idea.
So for a long segment stricture, would you recommend using 2 stents if the stricture is longer than 15 centimeters? And any recommendations again on suturing strategy for that situation?
Yeah, I think if the stricture is long, and those are rare scenarios, but one case I showed, the patient has a malignant stricture, and it was basically a neuroendocrine tumor inside the entire esophagus. So first stent place was a 15 centimeter stent, although, but then the proximal, there was tumor still seen at that end. So I think, yeah, stent in stent is a good technique. We don't have, and we use that in gastric strictures or sleeve leaks as well, because in US, for everything what we have available are these fully covered through the scope stent. So if the stricture is long, then you have to plan accordingly, and then you might have to use two overlapping stents in those scenarios.
One question. So companies often have small differences, right? So we're talking about, maybe a millimeter in difference between the largest over the wire versus the largest through the scope stent. So when it comes to the construction of esophageal TTS stents, are these small differences something you guys notice in terms of size or construction? Like you said, braided versus, hook and cross. Is that something you guys take into consideration or notice on your day-to-day use?
Yeah, so
I
I
would
think
say,
I never considered this, but I think I'll share some examples of where they can become significant. Is we have stent placed in duodenum, and there were some breakage of the stents is also possible, right? So then I think we did a deep dive into how these stents are construct, and one stent might be a better type of construct, might be a better fit for a very angulated stricture or something then. But I think for usual indications, strictures, I don't see if they make a difference. I think the all stents, what matters is there any anti-migration properties, the radial ports and expansion should be good on the stents. I think those are the main qualities I look for.
I agree. I think it's really not down to the nitty-gritty of the details, that in everyday, to cover most of your everyday practice of why you need stents. I think the overarching thing is what we talked about is just this major shift of being able to just easily and efficiently place esophageal stents in wherever you need to in the GI tract. And, again, goes along to why we've expanded into these off-label benign indications, but obviously there's a lot of data that show that this is everyday practice. So I think, for me, I don't look at those details more so for the workhorse of what I need a stent to do. It's really just efficient endoscopy. And again, choosing lengths and diameters is really based upon your anatomic needs. Not so much of those special nitty-gritty details, but I would say in the general workhorse of things, I think TTS, particularly large diameter for these benign indications, is the way to go.
Okay. One last question. So, are there any upgrades or modifications that you guys would like to see in the future for esophageal TTS stents? Like anti-migration features or maybe drug delivering therapies, those sort of things.
Yeah, I think so anti-migratory, there are certain stents that do have anti-migratory features, and then stents. There is an increase in size of these stents. Then also the flanges on the side, we have those are getting bigger, and then addition of a 22 through the scope, that was a good addition. I'm not aware of if there is any drug-eluting stents or these kind of stents available in US right now.
Yeah, I mean, I think that's sort of always been something that anywhere that you wanted to stent was something that was ideal, right? So you wanted to stay in the place where you put it. You don't want it to move. You want it to expand or seal where you want it to. I think drug delivery would be great, but then the caveat to that is, is there going to be more adverse events to it? Similar to what we thought about in the biliary tree too, anything to prevent sludge formation and obstruction so that we don't have to keep bringing back these patients for obstructive jaundice. So those are the things that I think in the long term and always has been a thought in further stent technology. But I think currently in this time, it's really just addressing the migration issues. And I don't know if it's going to all be, mitigated with just stent design. I think there has to be some sort of fixation situation. And I think shortly in the next wave of information and data that comes out, it's really going to be which is the best way to fixate, not just, the best method, but really more of a day-to-day practice, right? The realities of is it going to be widely available? Is it going to be cost effective? And it's going to be effective. Those are always the major points of why we move and shift to a new platform or new technology.
Okay. And sorry, one last quick question that came in. So covered stents in the duodenum, are there any concerns or issues with ampullary obstruction?
Yeah, I think that's something you have to be always be careful about. So the last one, the one case I showed, the patient had an ERCP and already has a biliary stent in. So I think that was not a concern there. But I think you have to, if you end up placing these in emergency situations, like the other case I showed, that patient had an ERCP at an outside hospital and had a perforation related to it, and the ERCP was extremely difficult, and then there was an obstruction there. So it's kind of more in an urgent setting we were using. But yeah, that's definitely, if possible, a stent can always be, an ERCP can be done if you are planning to keep the stent for a longer duration of time. So, but that's something that we have to be careful about. But in many cases, I haven't seen any obstructive jaundice related to them.
Okay. So thank you again, Dr. Singh and Dr. Yang. So this concludes today's discussion and Q&A. Thank you for joining us this evening, and look forward to seeing everyone at DDW this week.
Thank you so much.
Thank you. Thank you, everyone.